Okay. Right now, so what I might do if you
Okay, good evening. I'd like to welcome everyone to the Resnik Grand Rounds. As always, we have my good friend Hussein Tarek, who is the Chief Clinical Director of ITX Pros. And also today we have Rick Robinette, who will be on to answer any questions. Therefore, if you have any questions on the lecture and then any of the cases, please in the chat just put your questions and Rick will be very glad to get back to you. Now, the Grand Rounds has become very, very popular. We actually have 16 arches to treatment plan today. So what I've done is I have taken the Clinical Pearls lecture and I've reduced that in length so we don't keep everyone past 8 o'clock. So, but before that, what I would like to do, there's 9 doctors who have presented cases. I would like Dr. Tarek to go ahead and give the order of the cases so people realize when they will be when their case will be called. So
Thank you,
Hussein, if
Dr.
you could
Resnick.
go ahead and do that.
Absolutely, sir. So first doctor for today is Dr. Maria Benfeld. That's going to be our first case. Second is Dr. Anusha Koda. Third is Dr. Salam Awad. Um, Fourth is going to be Dr. Haley. Fifth doctor is Dr. Sam Cohen. Sixth doctor is Dr. George Gracious. Then we've got Dr. Farid Agani. Dr. Cassandra Murphy is number 8. And number 9 is Dr. Frank Kuzmin, sir.
Perfect. And just so you know, the order is as they get cases, they put them in order. So, and we'll do it that way moving forward. With that being said, I would like to talk about a topic that I actually had a couple questions on after the last grand rounds, and that is what happens when you place an implant or when you're drilling and you get too close to a tooth and you might damage the tooth, or you place an implant and it's in proximation to the tooth, or the implant is in the tooth. So let's talk about that because there's a lot of issues with this, a lot of medical legal issues. What I'd like to do is go over a case. This is a doctor who took our course last year, really great doctor and really sharp doctor. And he presented this at one of our courses. And I would like to show you how this case progressed from treatment planning through the actual orthodontic treatment and everything. But here's the bottom line. Patient had congenitally missing lateral incisors, 35-year-old, post-orthodontic treatment. Orthodontist sent it back to the general dentist. Medical history is unremarkable. The patient just wants implants in 7 and 10. Now, when we looked at the scan at the course, we were able to get 3.0 implants in. They're a little bit tight there, but we definitely had enough bone on the buccal and on the lingual. However, when we started to look at how much distance we had between the adjacent teeth, we always want to look in an axial image. So if you look on the left here, approximately 5.1 millimeters for the clinical crown, all the way down to 4.8 apically. If we look at between the actual teeth, we are looking at 1.1 on the mesial and 1.1 on the distal, about average. If we look at 10, 10 was the problem. First, only 4.2 for the clinical crown, but also if we look at the distance between the proposed implant position and the adjacent teeth, it was less than a millimeter, 0.8 to 0.5. Therefore, our problem and our question is a patient a candidate for dental implants? So if we look at first the clinical crown, how large should a lateral incisor be? Here we have 5 millimeters, 4.2. If we look at spacing, it will all depend on basically the lateral on the other side. So what we like to do is always look at the contralateral lateral. And a lot of times when there's congenitally missing laterals, the space will be a lot smaller. In health, usually, and when everything is ideal, the lateral incisor is usually 6 millimeters from mesial to distal. That is 2/3 of what a central is. Central is usually 9, so 2/3 of 9 is 6 millimeters. But we always want to check that with the contralateral lateral. So always check the other side, and that will also give you about the distance that you need. So if we look at the spacing, this was definitely a problem. Now, what made this case interesting is this doctor went back and talked to the original orthodontist, and the original orthodontist said that he could not move the teeth, therefore they just had to place the implants. So if we look at what is the problem, well, we know that apically we need to be very careful of getting too close to a tooth root. If we're less than 1.5, we know some bad things that can happen. So normally for a lateral incisor, we're going to use a 3 millimeter implant, 1.5 on each side. That gives us a total space of 6. However, if we get closer than that, what can happen? And this can be a real problem. So if we look at the actual tooth, what can happen to the tooth? Well, the tooth can get sensitivity. You can lose the vitality of the tooth. It might need endo, or worse, it could end up having internal or external resorption or even loss of the tooth. If we look at the implant, we can start getting bone loss around it. We can get an infection like this one, and then we can also lose the implant. So theoretically, we can lose the implant and also the tooth. If we look at how this happens, it can actually happen via direct trauma. So if you look at this case here in the center, this is a case where an implant was actually placed right into the tooth. So if you ever want to do a little experiment, take an extracted tooth, take your surgical drill, try to drill through the tooth with a surgical drill. It's not easy. So there has to be a lot of pressure when that happens. So, but direct trauma is the worst because you're going to alter the actual tooth. So you can see this is a case that we took out implant that was in too close approximation, and you can actually see the threads that are in the actual tooth. So again, this is not ideal. If we look at the literature, believe it or not, the majority of the literature on implants being too close to a tooth is in the orthodontic literature. And I talk about TADs in the course, and I always say, if you can go through your career with ever not placing a TAD, you're definitely ahead of the game. These are very, very tough. Usually you're placing in adolescence. There's not a lot of room between teeth to place these TADs. So that's why there's a lot of literature on what happens. But basically, what the literature is stating is, yes, you can cause damage to a tooth. So you can alter the cementing. You can alter the tooth. You can alter the periodontal ligament. The sooner you take that implant out, the greater the chance that it is going to repair. In the periodontal ligament here are cementoblasts. So we do have cells that actually will regenerate the cementing of the tooth. We can also have indirect trauma. Now, what do I mean by that? Indirect trauma is where we don't actually violate the tooth, but we violate the periodontal ligament, and that alters the blood supply to that tooth. So if we look at the periodontal ligament in health, the periodontal ligament's about 0.15 to 0.38 in the majority of studies. And we know there is a nerve, artery, and a vein within that periodontal ligament. However, there's a lot of cells, osteogenic cells, and as I said, cementoblasts and inflammatory cells also. So what happens when this periodontal ligament is damaged? It can alter the blood supply to the tooth and to this area, can lead to infection or problems with the implant and or the tooth. This is a study that showed when implants are less than 1 millimeter from the root, there's a high chance of external resorption. And again, this is from the orthodontic literature. So one problem that I do see is when doctors are evaluating, and I always say, look at it in the axial image, but measure it from the lamina dura, because we have to take in consideration that periodontal ligament. A lot of people will go right from the actual tooth per se, but we're not taking in consideration the periodontal ligament, and sometimes it can be inflamed, which is a problem. Now, as I said, the orthodontist in this situation didn't want to attempt this, because basically, here's what the thought process was. If he went to move these teeth, he's basically going to tip them. And when that happens, if you make more room at the clinical crown, what's going to happen is the roots are going to converge. You're going to actually have less space at the very end. So the bottom line is you have to be very, very careful. And when there's not enough space, it does have, these teeth have to be orthodontically moved, but they have to be translated. Translated means bodily moved. You don't want to tip them, because if you tip them, again, that will actually decrease the space. So in this particular case, the orthodontist wanted the patient just to sign a consent form saying they accept the risk. Do not do this. This will be definitely thrown out if it would ever be a legal case or a state board case. Patients really can't consent to neglect. We know that you can't place an implant with only 0.5 millimeters on each side. That is just not enough, and you don't want to put yourself at risk. If we look at what my recommendation was, I told them to get a second opinion. And after they move the teeth, and this is a take-home message, always have a CBCT taken prior to the debonding of the brackets. You don't want to take the brackets off and find out the teeth there's not enough space where they have to put them back on. Ideally, our golden number is 6 millimeters. That's at the crest and also at the center root and at the apex. When you're placing an implant, try to use a tapered implant. Most 3.0 tapered implants are approximately 3.0 at the neck, but they taper down to around a 2 or 2.2. Therefore, you have a little bit more wiggle room in that area. What I told the doctor, if these teeth couldn't be moved, you don't want to put yourself at risk or the patient at risk, conventional prosthetics. And the last take-home message was, don't take ownership to someone else's problems. This dentist, really a good guy, really smart. He saw this, and I just didn't want him going and trying to please the patient and please the specialist when this would have really gone downhill bad. So what ended up happening, patient did go to another orthodontist. They were able to translate the teeth, and this is what he had sent me. Now it's approximately 1.6, 1.7 on each side. So you went from 1 millimeter to 1.6 and then 0.5 to 1.7. So the moral of the story is it can be done. Unfortunately, I don't understand orthodontics. I don't know how they translate teeth, but it definitely can be done. With that being said, Dr. Tarek Hussein, I know you deal with this a lot. I mean, when you and I go through cases, do you have any opinion on that?
Dr. Resnik, you've summarized it in a beautiful way, sir. I 100% agree with you. Never compromise the quality of our work just to please the patient. That's definitely the reason why we're here. And thank you so much, sir, for mentioning that for today's presentation.
Okay, great. So I'm going to go ahead and I stop sharing.
And
Dr. Hussein will take over, and let's do the first case. Who do we have up first?
Dr. Maria Benfield. Doctor, are you here?
I am here.
Hey, Doc, how are you?
I'm wonderful. How are you?
Good, good.
Great.
Okay, so what do we have here?
So we have patient David. How old is he? I forgot. I drew a blank on his age, but he really, really nice man.
No
We have
medical,
been.
no medical issues?
I'm so sorry. No medical issues. I would say he's in his 60s. He is only on Zoloft. He when he came to me, had a lot of, as you can see, decay. I want to restore him, and also pretty much do a full mouth, not all on X, but and this might be what you recommend is all on X, but I want to preserve his teeth. He's in very
Okay.
good health. Um, as you can see, his occlusion is very heavy because he doesn't have the molar
Yeah,
occlusion.
so
But
he's a unilateral chewer here.
yeah,
So why don't we do this, Maria? Why don't we first start on the maxillary arch? So
perfect.
let's take a 360 on the 3D model, if we could, Hussein. So let's see what the condition of these teeth and see what they look like.
Yeah, sorry about that, Dr. Resnik. Lost connection for a brief duration, sir, but I'm back.
Okay, perfect. Okay, so let's go and let's take a peek at the 3D model.
You got it, sir.
And okay,
That's the
and
maxillary arch, Dr. Resnik.
yeah, so let's just look at the maxillary arch. Just do a quick spin around. Okay, so we're missing number 14. Now let's go to the pan view. Let's get a good overview of the pan. Okay, so a little inflammation actually in both sinuses. So Maria, this patient they don't smoke, right?
They do not, he does not smoke. He only has occasional drinks on the weekend, and that's about his social.
Okay. So
Yeah.
usually when we see bilateral inflammation like that, it's usually systemic or allergic, but that shouldn't be a problem. So let's first look at number 14. I'll tell you, Marie, right off the bat, the teeth don't look that bad where I would say they need to be
No, no, I
taken
think they're
out.
fine. Yes.
Okay. The patient didn't ask for them to be taken out, did he?
No, no, no. Just when ITX called me, they're like, all on X. I'm like, no, 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 all on X. So
Oh, okay.
I thought
Okay.
maybe.
So Hussein, let's do a cross section right in the center of that number 14. And did you place an implant? Did you
Yes,
treat an
sir.
implant? Okay.
I
Could you go
did
ahead
add a
and put that
5 by
in?
8. Here you go, Dr.
Okay.
Resnik.
Okay. So that's a 5 by 8. Okay.
Yes, sir.
Could we do a 360 on that implant to make sure that it doesn't enter the sinus? Okay, so it's right into the cortical plate. That's not bad. Okay, keep going, keep going. Okay, good. So let's look at it on a pan view if we could.
Right away, sir.
Okay. So Maria, you said that the patient does have force factors.
Only because, I mean, look at on the lower, you can see the PDL widening of that teeth.
Yes.
He
Okay.
needs to have that balanced occlusion, which will help him tremendously.
Yes, it'll
Um,
take a lot of the force off. So
yeah.
here's what I would say, Maria, where Dr. Hussein has that implant, it's basically in the ideal position. The only thing that I have reservations about is it does have a increased crown to implant ratio. Because
Mhm.
of that, you're going to want to decrease the force factors. So this is what we call implant protected occlusion. So you're going to narrow the occlusal table so that we don't have a large buccal and lingual cusp. So make sure we don't have any centric contacts, and I think you'll be fine. The other issue I see on this case is if you go back to the 3D image, Hussein,
Right away, sir.
yeah,
Here we go.
okay. And let's take that implant out of there, if we could. And let's look at a lateral view of it. So Maria, you might have heard when I talk about doing guide planes for the prosthetics. See how number 15 has a little bit migrated into that space? So
Yes.
what you want to do is parallel the distal of 13 and the mesial of 15. This way, number one, you'll get a broad contact area, which will help with force distribution. Also, it'll allow your insertion appointment to be very easy, simple, and you most likely won't have a proximal contact loss. So what I would say is an 5x8 is fine. Where he has it, we'll just play around with that a little bit. I think we can keep it below the sinus. Well, you can see here it is below the sinus. Now,
Nice.
if we go back to the Panorex, let me just point some out to everyone here. So in this case, I don't think we can see the ostium, can we, Hussein?
Oh, no, sir. It's cut off.
Okay, so Maria, if we were going to do what is called an SA2, where we have to go and bump up into the maxillary sinus, then we would most likely have to get another scan because it's not up high
Okay.
enough with all that. However, you don't have to do that on this case because this is going to be an SA1. You're keeping that implant below the sinus proper, good to go, no problem at all. Okay?
Wonderful.
Okay, so let's go ahead and look, and I believe you said bilateral posterior we're looking at on the mandible. So could we do a
Yes.
360 on that, Hussein?
Right away, sir. I'm loading the plan as we speak.
Okay. Or any of these teeth have to be extracted, Maria?
Well, I was noticing the expansion of the PDL on that
Yeah, number
lower right here,
28. Yeah, 28
28.
looks a
Yes,
little bit suspect. So let's take a peek at
yes.
that. Let's do, oh, you already planned it? Perfect. Okay,
Yes,
so
sir.
let's see what we have. Let's do the left side first. So right off the bat, you have 3 implants in the 19, 20, and 21 position. Could you go ahead and let's um, let's do cross. So you have them in real nice position. Perfect. So let's
Beautiful.
look at a cross section on that, Hussein.
Here you go, sir.
So what he's going to do is start distally, the most posterior, and he's going to move anterior. So let's go ahead and
That's number 19, Dr. Resnik, a 4.3 by 11, 4.3 by 10, I'm sorry, millimeter long implant at the side of number 19, sir. Next, we've got implant number 20, which is a 3.5 by 10 millimeter long implant, sir, at the side of number 20. 3 millimeters are maintained in between our fixtures, doc. Jumping to the next one, sir, is implant number 21, which is a 3.5 by 10, perfectly clear away from where the mental foramen anatomy is, and we're perfectly clear away from the laminate. You're leaving 1.5 millimeters to that structure, sir.
perfect. So I like your plan. Could you give us a quick axial image?
You got it, sir.
So to go along with that little lecture that I gave, let's go ahead and measure right there. Go back, go back. Okay,
I already took these measurements, Dr. Resnik, and it's 15 millimeters to the left side, 21.3 millimeters to the right side, sir.
okay, okay. And scroll a little higher here. So we have 15 on the other side. Okay. Okay. Okay, perfect. Okay, so I like how you have them spaced. Let's go back to the pan view. I think that's probably the easiest with the implants. Okay, so where Hussein placed these, he's definitely 1.5 away from each tooth. He has 3 millimeters between each implant, which is ideal. The only thing is, Maria, what I would say is this is going to be a duplicate of number 15. You're going to want to do a guide plane on number 18 there so that your prosthesis has one path of insertion. If the patient is a male, you did say male, right?
Yes, that's correct.
Okay, so he does have some force factors. I would probably splint these together. It will help with the force distribution and the
Excellent.
longevity because you have a little bit of a crown to implant ratio issue on this one. If you look at the anterior implant there, it is the crown to implant ratio is going to be probably 1-to-1 in that area. Also, Maria, when you do your treatment planning, let the patient know that you're going to alter some of their natural teeth. It looks like you might have some super eruption on those opposing on the maxilla, and it's always best that you explain that to the patient before you do it. Then they realize that you're not adjusting their natural teeth to fit your crown. So it just goes a little bit easier. But I like that plan. Do you have any questions on that side, Maria?
No, this is perfect. I really appreciate
Okay,
this.
so let's go to the other side. So on the
Absolutely,
other
sir.
side, the only question is, that 28 did not look healthy to me. So can we first
No, it
determine
doesn't.
so Hussein, can you go right over 28? Okay, there you go. So, I mean, that's circumferential PDL enlargement. Give
Yeah.
me let's do a cross section right in the center
You
of that tooth.
you got it, sir. Here we go.
Okay. And then could we do a 360 on it? So what he's doing is he's just scrolling around. Okay. Wow, that's a little bit of a defect there, Maria.
Yeah.
The patient doesn't have any problems on that.
No, he's asymptomatic.
Okay. So that I don't even that could be even more of a periapical infection there. That's a little bit more than periodontal ligament thickening.
Okay.
So, and that's been root canaled in,
Yeah.
wow. I mean, the
Yes.
only thing you're looking at is possible apicoectomy, which I really wouldn't do. I would this patient be apt to having that tooth taken out and just add another implant in that area?
Yes, he's a great patient. He will
Okay.
do whatever I ask him to do.
Okay, so here's what I would recommend. You don't want to do an immediate implant, and that would be contraindicated because
Okay.
you're right. If you look at where the apex is, the mental canal is right there. And that would be very, very dangerous. Also, you have to remove all that infection. So,
Yes.
what I would do is let's go back to the 3D model.
You got it, sir.
Okay. So if we look at the 3D model,
What
Maria.
are your thoughts on cantilevering? Since I'll have those two,
Yeah, I mean,
or
you
you still
can, but
rather
so
individually?
show her the anagonial notch here.
Oh, absolutely, sir.
Oh yeah.
Yeah, so he's already worn out his masseter
Wow.
um, by at least 3 mil. Lower that a little bit, so go all the way to the very end. Yeah, so his force factors are very significant there.
Okay.
I think you're more at risk if you try to cantilever. So
Okay.
here's what I would do is never put yourself in a position where you would ask yourself, I was trying to help out the patient, but it really wasn't the best thing for the patient. Now, if this patient was a 70-year-old grandmother with a denture opposing it, 100% of the time you would cantilever this. But
Okay.
in this case, I won't. So what I would do, phase one, Maria, I would extract the tooth, debride it, socket graft, then come back with delayed implant placement with either 2 or 3 implants there. I see he has already 2 implants. Depending if the force factors are as high as what you say, then
Mhm.
ideally there should be 1 implant for each tooth. And that's how you practice safe dentistry.
Okay.
Also, if you look at from the occlusal, let's look at that 3D from the occlusal.
Here you go,
Again,
sir.
you're going to have to do a little bit of recontouring on that tooth also, the molar. So 31
Yes.
is going to need a little recontouring. So all of these are going to need
Okay.
recontoured.
Very good.
But
Very
this case, other than that lower right, is going to be very, very straightforward,
Oh,
and
good.
it's going to be ideal. The only thing with the number 14 is, and we'll talk more about this in the modules, the implant protected occlusion, where we'll show you how to protect the implant via the occlusal table and occlusal principles. Okay?
Thank you so much.
Okay, do you have any questions?
No, sir. I really
Okay,
appreciate you.
okay, perfect. Let's go. Next case.
Is Dr. Anusha Koda. Doc, would you mind please unmuting yourself and describing your case, Dr. Resnik?
Okay, so hi, Doc. How are you?
Hey Doc, I'm doing good. How about you?
Good. Do you want to put that up, Hussein? And
I'm
we'll.
loading it right now, sir.
Okay. So, Doc, could you tell me what area are we looking at?
We are looking at number 12, Doc. She
Number
was
12?
mhm.
Okay. So let's do a quick 360 on this. Any medical issues on this patient?
uh just depression and acid reflux.
Okay. So right off the bat, Doc, here, let's look at it from a lateral view.
Mhm.
Okay. So take out the teeth there for us.
You got
Hussein.
it, sir.
Okay. So do you see where we have a little bit of a vertical defect? Okay. Now
Uh-huh.
put the teeth back in.
Here you go, sir.
And now let's look at from occlusal. So now do you see, take out the teeth? So Doc, do you see the concavity there? So we've lost a little bit of bone there.
Uh-huh.
Actually, a lot of, probably about at least 2, probably 3 millimeters of bone. Now let's go ahead and Doc, let's see what the cross section looks like.
Sir,
So what do we have here? Have you planned one out here, Hussein?
I did add an implant over here, Dr. Resnik, but I'm using, sir, a 3.5 by 8 millimeter long implant at that area, Dr. Resnik. Very limited bone to the facial and to the palatal, sir. And we're in very close proximity to the laminate of the adjacent teeth with a note that there is a pathology related to tooth number 13, Doc, to the
Okay.
distal aspect of my fixture, sir.
Okay. Can you show us that? Okay. So right off the bat, number 12 is compromised in
Mhm.
width and height. So where's this? You said on number 13, there's a infection or a
Yes, sir.
defect?
There is, here you go, Dr. Resnik. Can you see that portion over here, sir? Where I've
Okay.
got my cursor.
Okay. Is that 11 or 13?
That's number 13, sir.
Okay. Okay. So, okay. Let's go ahead and let's do a cross section over number 13.
You got it, sir.
So what we have is a defect on 13. We have a dilaceration on, okay,
11.
and on 11. So go ahead, do a 360 on this. Just scroll through. Oh yeah, okay. Okay, I think that's okay. I'm more worried about this dilaceration. So let's go ahead and let's look at the 3D model. They segmented this?
They did, sir. And we'll
Okay.
switch it on right away, Doc.
Okay, so show them how you can see how close you are. So what he can do is remove all the bone
Mhm.
and blow that up for us so we can see. So what size implant is this? 10. Okay.
Yep, 3.5 by 10, sir.
Okay, that's why you didn't go longer. Okay. So, but I think we're compromised in, so Doc,
Mhm.
the
Yes.
reason why he didn't go with a longer implant, take away all the bone, just so you
You
see
got
the
it, sir.
teeth and the implant, so she can see it. Now,
Mhm.
let's move it around so she can actually see the approximation. Okay, Doc, you see how close you're getting?
Yes. Uh-huh.
Okay, so you don't want to go longer. And, if you didn't have a CT, you would have never even seen that because a periapical would never have shown that. So that's pretty close right there.
Uh-huh.
You know what? That's going to have to go to an 8. So can you change it to an 8? See what it
You
looks
got it,
like?
sir. Absolutely.
That's going to be a little too close, Doc. I don't like that.
Okay. Mhm.
Okay, so what he'll do, there's very little difference between an 8 and a 10 millimeter implant.
Mhm.
When a force is put on the implant, it only goes down the implant approximately 5 millimeters, so it never gets to the apex. The reason why we want longer implants is for primary stability. But now you're plenty away from that dilaceration. However, let's go back to the cross section on this, Hussein, because I
Here you go, sir.
believe that this one is really compromised. Yeah, so you don't have, first of all, the bone quality is poor. Number two, you don't have 2 millimeters. You don't have 1 millimeter on the buccal or the
Mhm.
lingual. So, Doc, here's what I would say. I would say that this case needs to have some bone augmentation. So ideally, we build up the bone first. So phase 1 of the treatment would be we build out in width, and then
Mhm.
go back to the 3D image so she can see that width problem. And let's look at it from a occlusal view.
Here you go, sir.
Okay. So see how much of a defect there is? It will be a very easy graft because that's a concavity. Just build that out enough, and then you'll have enough bone on the buccal and on the lingual. I'm a little worried it's already a 3-5 implant. So for a bicuspid, that's really probably the narrowest diameter that you would even think of doing. So that just needs to be built out where he has that yellow line. Does that make sense, Doc?
Yes, it does.
So phase one, GBR, phase two, delayed implant placement, and that implant we can push a little bit more to the facial. So if you look at the cusp of the canine, then look at the central fossa of the posterior teeth. That's where that implant should be coming out. See how far lingual it is? And he placed it there because that's where the bone is, but it needs to be more facial. Okay?
Okay, Doc.
Great. Thank you for presenting that. Okay, let's
Thank
go.
you,
Next
Doc.
case. Okay. Who
Next
do we
case
have?
is for Dr. Salam Awad, Dr. Resnik. Dr. Awad, would you mind unmuting yourself, please?
Yes,
Hi, Doc. How are
doctor.
you?
I'm
Good.
good.
How
I'm
are
good. How
you?
are you? Good.
Good.
Thanks for
Okay.
that.
What do you have for us today?
Okay, we have Mohammed Rizk. He's 49 years old, healthy. He's not taking any medications. Um, he needed implants in sites number 11, and he had actually before he had the number K, baby tooth in
Okay.
the site number K on the lower left. I
Okay.
did the GBR guided bone regeneration number 11, and then I also did number 19, 20, and 21, if I
Okay.
recall.
So Doc, why don't we do this? Why don't we look at the maxilla first?
Okay.
So
Thank you.
we're missing
Thank you.
number 11. Okay, is that
Yes.
correct? Okay.
Yes.
So Hussein,
Let me see because this
let's
one's
do a
hard.
cross section on number 11.
You got it, sir.
This is
Okay.
one too.
And if we could blow that
Thank
up.
you.
Okay. Did you plan an implant here?
Yes, sir, I did. I did
Okay,
add a
Is that a
3.5
little
by
Let's see.
30.
Hussein, is that a little
Maybe they
motion
want like this one.
artifact?
No, it's okay. Oh,
Yeah,
actually, this is good. I need this
yep.
one.
There's an artifact or
Yeah.
like there are noises, Dr. Resnik, from the scatter of the restorative portion on the
Okay.
remaining crowns. Yes, there
Okay.
is some noises, sir.
Okay. So whenever you see it fuzzy like that, it's actually a double image because
Yeah, I
there
mean,
was
I'm
a
not
little
too
bit
good
of
at it.
motion. So you have to be very careful of that. Okay. So
Thank you.
go ahead and let's tell us about this, what you have. You have a 3.5 in there?
Yes, sir. A 3.5 by 13, Dr. Resnik. That one as well is mesodistally compromised over here to the distal aspect. I'm just
Yeah, number
scaring
12 doesn't look too good. So let's look at
through,
number
sir.
12.
Let's take a look together, Doc. Here we
Okay.
go. And it's a rotated tooth as well, Dr. Resnik. It's eating my mesodistal space.
Okay. Doc, were you
Yes.
did you see this this
Yeah.
defect? Yeah, so that's more than periodontal ligament thickening. So there's definitely a defect at the apex
Of number
and
12.
on number 12.
I see it now.
And also it looks rotated. Could you show us on an axial scan so everyone can
Yes, sir.
see that? Because what it looks like it's doing, Doc, is so it's impinging on our available space there. So that's why he has a 3.5 there, which you really for number 11 is not the most ideal. Or do you have a 4.3 or a 3.5 implant in there?
It's a 3.5, sir.
Okay, yeah. So the reason is, Doc, we disclude off of that cuspid, and the cuspid single implant is very difficult to restore. And we'll talk about that more in the course, but when you restore it, what you want is a very shallow anterior guidance on it. So when the patient discludes, you want to disclude as fast as possible. If you have a long slide on it, what ends up happening is it increases the shear forces, and that becomes problematic. With that being said, what is so you haven't seen number 12? Have you seen a regular periapical x-ray of number 12?
I don't see the periapical radiolucency on a regular X-ray on a
Okay.
PA. I don't see
Yeah.
it.
So,
I mean, I just saw this. I wasn't aware that he has a
yeah.
typical
So Doc,
radiation on
I
the tooth.
think this one is definitely compromised, number 12. So what I would do is do a further investigation into do a clinical you want to pulp test it, you want to take a periapical x-ray, you want to probe it. There might be a perio issue on it. There's definitely an endodontic issue on it. This tooth doesn't look real healthy to me. The other thing that I don't like is show us where that implant is in approximation to that radiolucency.
Here you go, sir. Right through it.
You have it right through it, Doc. I really don't like that. I don't think an endo would cure that. So I would look at possibly extracting that tooth. Again, further do a clinical exam on it. If it's as bad as what we're seeing right here, then I would probably recommend this. I would probably take that tooth out, debride it real good, socket graft it. At the same time, build out number 11. So just build out the facial aspect of it. Therefore, we can get a 4-3 in. Can probably put 2 4-3s in, and this case would be more ideal. I think if you try to place an implant here, you're not going to have, number one, you're not going to have enough buccal bone. Number two, the distal of this is going to be in soft tissue and or infection. So you have to be very careful. So I would take a step back on this one.
So what's the buccal lingual width that we have right now?
So
with
if
this?
you go on the cross section, so
Right now, Dr. Awad, it is, sorry, sir. But it's
Yeah.
still, it's hazy to the facial aspect,
yeah,
Dr.
so
Resnik.
show them. So Doc, Hussein, show them the one image of the tooth, the bone, and then the mirror image. So you actually see two. Because of the motion artifact, you actually need another scan on this
The
to
patient
determine it.
moved. Yes.
The patient
Okay.
moved. And
I see.
so that's one, and then there's a second one out to the facial of it. See right there? So actually there's probably 3 images. So we don't have a really a good accurate assessment. I can kind of tell just from looking at it that you're probably not going to have enough bone. Remember, even if we do put a 3-5 in, you need 2 on the buccal, 1 on the lingual. So you're looking at 6.5, 7.5 millimeters, and you certainly are not going to have that. So,
Okay.
so this is definitely going to need a graft no matter what, and or possible extraction number 12. Okay.
Okay.
Okay. And did you have on the mandible? We had an issue on the mandible too, right?
True. Yes. 2
Okay.
implants.
Okay, so we want to look at the mandible on this, and you were
I'm loading
looking
it
at the
right now, sir.
lower left. Is that
Yes.
correct? Okay.
Yes.
So, and you said you grafted this because you had a primary molar, correct?
Yes. Yes. He had a primary molar.
Okay.
And he did not have any teeth in there other than the primary molar.
Okay. So let's go ahead and take a look.
Here we go, Dr. Resnik.
Okay. So we have a primary molar on the right. We have 4 anterior teeth that look to be infected.
These were referred to endo, and endo ended up doing retreats and then periapical
Oh,
surgeries, and
are you
he's been
serious?
he's
Okay.
been through a lot, like
Oh
when
my
it comes to
gosh.
those
Okay.
anteriors. He was
Yeah.
an accident, and that's what happened. So he's trying to hold on to his teeth, to be honest, as long as he can. He doesn't
Okay.
want to lose his teeth, especially that he comes with already like missing teeth. He has a history of missing teeth, you know.
Yeah.
Primary, we
So
can see the primary molar on the right side
yeah.
as well, lower right.
Yes.
Yeah.
So Hussein, let's scroll through these anterior teeth.
You got it, sir. Here we go. I'm going to start with the canine, Dr. Resnik.
Okay.
Here's the periapical pathology, sir, related
Wow.
to the anterior.
They did apicos on these? Is that what you said?
Yes.
Wow.
And
Okay.
they're, to be honest, they're saying like if I send you the report, it says it's stable. So
Well, yeah, it's stable when the patient got out to the their car,
Yeah.
but after that, no. Okay.
Yeah.
I tell you, Doc, I don't like this one, to be honest with you. I think placing implants on the lower left would be probably a disservice to this patient because here's what's going to happen. They're going to lose that anterior ridge
Implant.
or yeah. And when they lose that, you're going to have to do an osteoplasty, which is going to lower that bone in the posterior too. And you could do whatever you want. You could do an FP3 fixed, or you could do an RP4 or an RP5 removable if you just take out those teeth. If you place 3 implants or 2 implants on that lower left, they're probably not going to be, I mean, they'd be used in the final prosthesis, but this patient's going to end up, the patient already ended up paying for apicoectomies that really were very suspect. So, I mean, wow, I would definitely, my opinion, Doc, have a talk with them and explain the poor prognosis of these teeth. And I mean, I think the patient would do a lot better just taking these out. And he could have anything he wants. He could have fixed or removable, and it would be a very high long-term prognosis. Right now, this is a time bomb. And that one area where number 24, 23, 24 area, that they're going to lose that. I mean, they did an apico on this. They didn't do any bone grafts. I mean, there's almost no
some
bone.
endodontists don't do bone grafts too. I
They
mean,
don't?
I noticed that some of them do bone grafts, some of them don't.
Yeah. Well, I mean, apicoectomies have such a poor long-term prognosis. If you look at implants versus doing an apicoectomy, implants win 100% of the time.
Yeah.
So, Doc, I just think placing implants on the left is just going to be a compromise. I
So
really do.
do you think removing all the lower teeth and doing like implants on the
Oh,
lower?
definitely. So Hussein, did you plan anything here other than those 3?
No, I just planned those 3, Dr. Resnik.
Yeah. So Doc, here's what I would say is have a talk with this patient, show them this scan, show them how bad these teeth are, and tell them that long term, these are not ideal. And then you can, between the frame and you have enough bone there that you're fine. You can do whatever you want. The patient could have fixed, the patient can have removable. So just by placing 2, 3, 4, 5 implants between the frame and all this bone is going to have to be leveled after the teeth are taken out. So in the posterior, you're not going to have enough bone to place implants. But I think you have to have a long talk with this patient. And I just hate for them to spend any more money or put you in a position where you're placing implants that really aren't going to be ideal for the patient's
I see.
prosthesis. Remember, the patient probably wants to look good, so aesthetics and function. By just doing implants on the left, they're not going to have either.
So
So
let's say we plan the implants. Would you remove all the teeth and then place the implants at the same time, or did you immediately?
Yeah, I think you can, Doc. So scroll through there again, Hussein.
You got it, sir.
So he's going to do a cross section, scroll from one frame into the other.
Here we go.
And we'll be able to see exactly, because what you're going to end up doing, Doc, oh, wow, that's pretty thin. Okay. Yeah, I think you'll have enough bone, though. You might have to graft one area, but see how thin that is, Doc? Yeah. So what we can do, Hussein, why don't you plan this out later? We don't have time right now. Doc, we'll plan it out for you and send you an email with it. But I think you could do 2 implants or 3 for an RP5, 4 implants for an RP4, 5 implants for a FP3. So you could do fixed or removable, and you could most likely do this immediately. Definitely. Okay. Okay, Doc.
Thank you.
Perfect. Okay, next case. Who do we have, Hussein?
Dr. Haley, Dr. Resnik. So,
Oh,
Dr. Haley,
Mary.
unmuting?
How's Mary doing?
Good. How are you doing?
Good, good. What do you have for us today, Mary?
Okay, so I have a patient. He's in his mid-50s, no medical concerns. He is a new patient, but I am friends with his wife.
Okay.
And he had number 6 removed, she said, about a year or a year and a half ago. He also is missing 19, 20, 21, 29, and 30, but then 28 is compromised. If I can try and restore it, I will.
Okay.
But I
So
wanted to
why
get your opinion on
yeah,
it.
so why don't we look at the maxilla first? Let's do a cross section on number, is that not, that's number 6?
Yes, sir.
Yes.
That's number 6.
Okay. So number 6, let's do ooh, okay. We're a little compromised. Let's scroll back and forth, see what we have. Okay, the other way.
Here we go.
Oh, yeah. Okay. So Mary, you've lost a lot. Have you put an implant in this one?
Yes, sir, I did. I added a 4.3 by 11.5 millimeter long implant at the side of number 6, thinning the labial plate of bone over here, the apical third, just for a favorable prosthetic position.
Okay.
And it's a 4.3 by 11.5, Dr. Rezzi, for the side of number 6, sir. Clear away
Okay.
from the laminate urus.
Yeah, so Mary, this one will be a slam dunk. Where he has it, see where it's coming out in relation to the mandibular canine. It's
Yes.
ideal. You can do it screw retained. The reason that he has 11 and a half and not longer is you would end up perforating the buccal plate, but you don't have to worry about that. You have so much on the buccal. You'll maintain the soft tissue drape on this one very easily. I like where he has that, and that's a slam dunk. The only thing is I probably would do that guided, at least do a pilot or a universal guide on it, because
Yes.
you don't have a lot of wiggle room on this. So I would just again do a guided, and that's a straightforward home run on that one. Okay.
Perfect. Good to hear.
Okay, let's go downstairs and see what we have
I
down
have a
in the
question on
mandible.
that. Is
Yeah.
there a minimum thickness for I know on the buckle you want about 2 millimeters at the crest.
Yes.
At the apex, is there a minimum thickness?
Not really, because it's not stress bearing. The reason why we went 2 on Noah, 2 on the buckle, is because that's where all the force is going. At the apex, the forces do not distribute all the way down to the apex. We only need that apex for primary stability. Once it integrates, we're fine.
I was
And
worried about that too, because it looked like there wasn't much there.
yeah, the way that he has it placed, if you do that guided, you'll have no problem whatsoever. So
Okay.
it won't perforate the plate. Yeah. Usually what will happen is, if anything, it will deflect a little bit off of it because there is a cortical lining there. So I wouldn't worry about that.
Okay, that's good to hear. Thank you.
Okay. So now this patient has some attrition in the lower anterior teeth. It also looks like, Mary, they have some super eruption of this whole segment. So they have some denoalveolar extrusion. So let's first look on the left side. So let's do the left side first. We're looking
You
at
got it.
what, 19 to 21. Is that correct?
Yes, sir.
Right.
That's an affirmative.
Okay. Did just for time purposes, did you plan this out?
Yes, sir, I did. I did add 3 implants to the left side at the size of number 19, which is the one I'll be starting with. Is a
Okay.
5.0 by 10.
Okay.
Low bone density, Dr. Resnik.
That's perfect.
away
So
from-
far away from the nerve. You're type 2, type 3 nerve. Let's go to 20. Go ahead.
4.3 by 11.5, sir. Clear away from the mental frame and plenty of
Okay.
bone coverage to the facial and to the lingual. 3 millimeters in between our fixtures, Dr. Resnik. Then
Okay.
number 21 is a 4.3 by 11.5. Clear away from the laminate dura of the adjacent tooth, maintaining 1.5 millimeters to the laminate dura of the adjacent tooth, and that's the left quadrant, sir.
Okay. So Hussein, I like where you have the implants. The only thing is, Mary will probably also do this guided. So I think those implants can come a little bit more superior. You can do this later. That will just decrease the restorative space a little bit. Yeah. I think that's more ideal. Perfect.
Would you splint those 3 implants together?
Well, I'll tell you what, Mary, is this a male or a female?
Male.
Male. Do we have the mandible? Can we see the anagonial
Oh.
notch?
Absolutely, sir.
Let's see, or is it cut off? It is cut off. Well,
Yeah,
yeah,
Sorry, I had
it's
the endodontist next door to it.
oh, no problem. No problem. Mary, I look at those anterior teeth,
A
and
lot
to
of
me
wear.
that he probably has wear. It's going to be a higher restorative space crown implant ratio issue. I would splint them.
Okay.
You'll never go wrong splinting them. And if something happens, you always ask yourself why you didn't splint them. And
Right.
you've heard the whole story on splinting, about the flossing and all that. So I don't think I would err on the safe side. This patient definitely has parafunction. You just don't want them rocking those implants out. They have a poor crown implant ratio because of where the bone level is. Okay.
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 What do you
Now,
think
go
about
ahead.
that 28?
Okay, so let's look on the other side. So you have 3 implants on the other side also, and
Yes, sir.
number 28. What is your concern about 28, Mary?
I was gonna try and keep it in there. It would need a root canal post and crown. It's compromised, but if I can try and keep it in there, I'd like to keep it in there. But I wanted
Well,
to get your opinion.
yeah, I mean, it does have buccal bone. This is just fractured. The clinical crown's fractured on it.
Yes.
Okay,
And
I
there's
think
decay, but it
but
looks restorable.
it's definitely restorable. I would do the root canal and crown on it and be fine. You're fine on that. That if you remember, we look at a 5-year prognosis on that. That has a very good 5-year prognosis, I
Okay.
would say. Okay, so let's look at what else you have here, Hussein. So you planned
29,
this on
sir.
29.
Yep.
Okay.
4-3 by 11-5. Good bone coverage to the facial and lingual, clear away from the mandibular canal, clear away from the laminature of the adjacent tooth, maintaining 3 millimeters in between my fixtures, Dr. Resnick, with number 30 being a 5-0 by 10. Now I added a third implant, number 31. With this one, I went with a 5-0
Oh,
by 8 because of the lingual concavity, sir.
Okay. So, yeah, Mary, I tell you what, you could do 2 or 3 implants there. I thought you said you only want to go to 30.
I
Do
was only gonna go to 30, but if you think 31 is
yeah, do we have an opposing on this? Do we have?
Uh,
We
no,
only have
sir.
number 3.
Yes,
We
sir.
okay. Mary, you could probably get away without 31.
okay.
All you have to do is pick up let me see. Look at the pan view again. The
Yes, sir.
pan's not going to be ideal, but we can just get a view of this to see if that 30 implant would pick up. Yeah, it's going to pick it up. Okay.
Okay.
And we can probably modify that a little bit too. So I would probably I think 31 might be a little overkill. I don't think you really need that. So
Okay.
if they had a second molar, if they had number 2, I would say yes, but since they don't, I don't think you need to.
Okay. No,
Okay.
that looks really good. Thank you so much.
Okay. Okay, Mary. Thanks for presenting that. Okay, good. Let's wow. let's go. Next case. Who do we have?
We've got next, sir, Dr. Sam Cohen. Dr. Cohen, would you mind unmuting yourself, please?
Is this Sam or Noah? Or do we have both?
I think we've got Dr. Noah, but
This is
in
both.
this case,
Oh, we have both.
perfect.
Okay, good. Okay, so
Hello.
you have 2 arches too. So let's look at the maxilla first. So
Yes, sir.
hey,
Loading it right
docs,
now.
what do we have on this one?
Well, we want to know if we can graft this or if it's not even worth attempting because the bone is so thin. We can't get implants in right now. It'd have to be a full extraction and graft. I'm just not sure if we can graft it.
So Sam, you're not looking at an immediate load this case, right?
No, this is a full
Okay.
extraction and full ridge graft, and then later full arch all on X fixed.
Okay.
She requires a fix. She won't take a removable prosthesis.
Okay, so let's scroll through here. Let's go from molar to molar.
Here we go, Dr. Resnick. So that's the right quadrant, sir, and I'm scrolling towards the patient midline right now. Bone density doesn't look that great, Dr. Resnick.
Yeah. Okay, keep going, keep going. Keep going. Okay, keep going. Okay. Well, you two will be busy on this one. So let's go back to the pan view on this.
Yes, sir.
So here's what I would say, guys. Actually do a 3D image on this and let's look at occlusally.
Right,
I
like
mean,
that.
the upper looks in better shape. The lower is what we're really concerned with. 'Cause I
Okay.
don't know if we can graft
Yeah.
it.
So here, let's take out the teeth.
Sure.
Here's what I would do on this one, Sam. Now, you don't have to graft the entire maxilla. What are our key implant positions? We have the cuspid, the molar, and then the bicuspids, and possibly one central. On this is more of a square arch form. So Sam and Noah, I think that you could probably get away with just putting the cuspid implants in. You really don't need one in the anterior. With that being said, you could take all the bone and just build up those cuspid and in the molar areas. You most likely are going to need some grafting, possibly in the sinus. So what I would do is I would go into the bilateral molar areas, do build up the ridge a little bit, and also the canines. So take out the teeth, build up those areas, and then rescan them by 3 months. And I bet you that you'll be fine that this one definitely can be grafted, not a problem. You might have to do like an SA3 technique in the posterior on the molars, but I think you'll be fine. Now let's look at the bottom because you think the bottom is more of a concern. Is that what you said? Okay.
Right.
So
Because
so
I don't even want to take the teeth out if I can't predictably get implants in for a fixed prosthesis.
okay, so let's take a look here. Is it real
I'm really
thin?
good right now,
Is it,
sir.
is that what
It's
you're
really
saying?
thin.
Okay.
There's no way you can graft posterior to the mental. It has to all be between the mental
Okay.
foramen, but I'm not even sure if a buccal graft will take because it's so
Okay.
thin.
So let's do a 360 on this,
You
on the
got it, sir.
3D. Okay. And let's look at the lingual. Wow, there's not much in the posterior. I agree with you. And it's an hourglass. You
Yeah.
got an hourglass here. Okay.
Yeah.
So let me explain this. This is an hourglass mandible. They say it's approximately 4% of the population. I disagree with that. I see it more often than that. Let's do a cross section between the foramens. Wow. Okay. Okay, let's go between the foramens. There we go. Okay.
Here we go, sir.
You're gonna freak everyone out there. Okay, keep going. Keep going. Keep going. Keep going. Keep going. Okay. Oh my. Okay, let's look at the 3D model.
Yes, sir.
Take out the teeth. Is Dr. Robinette on this, Paul? Can he talk?
I'm gonna unmute Dr. Robinette in just a second, sir.
Okay. Yeah, let's look at it from a facial. So Sam and Noah, here's the deal on this one. What you need to do, this is an hourglass. And the reason why I asked about Dr. Robinette brought this exact same case to the Institute 25 years ago. And I did this procedure with him. And the implants are still working great. So Hussein, show
It's
him
working
a
very
line.
well, Randy.
It
It's
is?
working.
Okay. Doesn't this
Yes.
look like your case?
Yes, sir,
Okay.
it does.
Okay, Hussein, do me a horizontal line about 8 millimeters below the ridge to where the bone has to be removed.
Yes, sir.
So Sam and Noah, Sam, you got this, no problem. Okay, so here's what you do. You use a piezo or you use a crosscut Fisher burr or tapered crosscut Fisher, and you pilot holes, and you take that whole top off as one piece. Okay. And then what you're going to do is turn it upside down and rotate it down below. You're going to screw it in and you'll do a block graft on that. It'll work, no problem. It's autogenous bone. And then you'll need to use a little bit of allograft where you have voids, but we'll walk you through it. Rick did the same thing, like I said. Is that 25 years ago, Rick?
Yes, sir.
Okay.
Yeah.
We've been around a long time, so
Yes, sir.
that's
So
exactly
we'll bring
how
this
you
to
do
the
it.
hands-on course then.
Oh, I'd love to do this at
We'll
hands-on
do it
course.
because
Yeah.
I saw it's coming to Michigan, right?
Yes.
Yeah. So
Oh, we'll
we-
definitely do this.
Yeah, it'll be
Oh, this
20
will be a
minutes.
good one. You'll love this one. You'll love it.
Yeah.
And you'll see how easy it is. So, but actually,
So should we take the teeth out and graft first, or is this
No,
all in one surgery?
I do it all in one.
Okay.
I do it all at once. Why put the patient through that? We can do
Right.
it all at once. Yeah.
Okay.
And then
Okay.
we're gonna they're gonna be in a healing denture
Yes.
after that. And pretty much just the denture will just pretty much contact the buccal.
Yeah, we'll hollow it out. You'll use the buccal. The patient does have good buccal shelves there. So we'll use the primary stress bearing area significantly to take the pressure off of that ridge. However, with the graft, we're going to just have to take that flange off. So you'll make an interim denture and then we'll cut the flange off, most likely.
Okay.
But I'll walk you through this one because when we do this, we have the flange a lot thicker. So a lot of times you can even hollow it out there. Yeah.
Okay.
But we'll screw it in. So even with pressure on it, it's better than a GBR. And there's no way to build it up with the GBR. No way that would work.
Yeah, I tried that once.
Yeah. Yeah.
It all dissolved.
It does. Or it migrates. Yeah. Okay, good. Yeah, you guys can double team it. We'll do it together.
Yeah.
I'd love to do. We'll
gonna bring it.
videotape that one. Okay. Let's keep going. I know we are past 8 o'clock, but I hate to not get to everyone's case, so I'll do them as fast as I can. Sorry
Next
about
case,
that,
sir,
everyone.
is
This is
Dr.
George. Oh,
Yes, sir.
okay, George. What do we have?
Hi, Dr. Resnik. Hi, Dr. Hussein.
Good. How are you?
Hey,
I'm
Dr.
good.
Ward.
So
Good. What do we have, Doc?
I have a 33-year-old female. She has hyperthyroid,
Okay.
and she's taking methylmazole for that.
Okay.
She lost 8 and 9. She said 20 years ago,
Okay.
and she's wearing now a partial denture to replace 8 and 9, and she wants to get implant.
Okay. So let's do a cross section on that. Number
got it,
7
sir.
and 10 are all right.
They're okay, yeah.
Okay. Okay. Is this
8
8 or
area,
9?
Dr. Resnik.
8?
Yes,
Okay,
sir.
keep
That's number
going.
8.
Keep going.
Here is number 9, Dr. Resnik.
Okay, perfect. Okay, hold it right there. Now George is experienced at this, so he'll have no problem whatsoever. You can see that's a catcher's mitt. Concavity. Did you plan implants on this?
Yes, sir. I did add 2 implants, Dr. Resnik.
Okay, go ahead and throw them in.
3.5 by 13 over here at number 8, Dr. Resnik, and a 3.5 by 13 at number 9 area. We do have exposure to the facial aspect of that implant on both implants, actually, sir.
Okay, no problem. George, you're just going to do a GBR.
Yeah,
You'll
I'm
probably
planning to do
just
GBR.
need 1 10th screw on each side because it is a concavity. So you'll first go in, decorticate it, and this will be an easy graft. The only thing that I would say on this is it might be a little bit more of a FP2, so make sure you use my consent form for the implant placement. It's a female, is that what you said?
It's a female, yeah.
How old? 30?
She's 33.
33. High smile line?
Not too high, no. I attach
Okay.
pictures also for a smile.
Okay,
But
I don't think we have those, but
I
okay.
underlined the FP2 and explained it to her and your
Oh, you
consent.
did?
Yeah.
George, you're ahead of the game. Okay, you're doing the next webinar, so no, I'm just kidding. Okay, good case. And you should have no problem. I like it. And
Awesome. Thank
you were right on with the FP2. So go ahead, get the next case up and I'll tell everyone. The reason is you never want to guarantee the patient that the clinical crown is going to be the same size as the adjacent teeth. So with that consent form, it goes over that. Patient understands it. As long as you inform them, that is great. If there would be a huge high smile line, then an implant might not be an ideal solution there, and maybe a fixed partial denture might be better than that. But with this case, he already took care of it, so it's good to go. So phase 1 will be graft. Phase 2 will be the 2 implant placement.
Awesome. Thank you.
Okay, perfect. Okay, who do we have here?
Next case is for Dr. Fareed Agani. Doctor, would you
Okay.
mind please unmuting yourself?
Okay, what do we have, Doc? How are you?
I think we might be missing Dr. Farid for today, Dr. Resnik.
Oh, okay. Okay, so go to the next one then. We'll
You
get
got
him
it, sir.
next week.
Perfect. So next case is for Dr. Cassandra Murphy. Dr. Murphy,
Oh,
would you mind unmuting yourself, please?
hi,
Hello.
Dr. Murphy. How are you?
I'm doing well.
Good. Okay, Cassandra, tell us what you have for us.
All right. So Artis is 72. She was on daily Forteo injections for 2 years for osteoporosis. She had her
Okay.
first infusion of reclassed June of 2024. I spoke with John Cinciola, and he gave me some screenshots out of the textbook of the reclass stuff. I just talked with her physician earlier this week. He felt like he agreed with you have the conversations with her, inform her of everything, which we have. But being that she's already 9-10 months out from her last infusion, he was comfortable with that. We'll delay her second infusion till
Okay.
osteointegration is.
Okay, let's back up on this one, Cassandra. So this one has the potential to have some issues.
Yep.
So just for everyone's knowledge, Forteo is a parathyroid hormone that is given for osteoporosis. There's actually no issues with taking Forteo. The problem is it doesn't work that well. That's why they most likely change the patient to reclass. The problem with reclass is it is Zometa. So it's Zometa, but a lower dose. Zometa is the IV bisphosphonate that's used for multiple myeloma metastatic cancer patients. So the problem with reclass is it is the worst type of bisphosphonate, and it is IV. So it is very, very potent compared to the oral forms. Now, if you look at the latest, and the new textbook hasn't been out, but every textbook I keep having to modify the recommendations. There are two issues that you have. The physician isn't going to know about it, but if you look at the package insert, it basically says, do not do oral surgery, any type of oral surgical procedures when the patient is on reclass. Now, the issue that you have with bisphosphonates is the half-life. So it was once thought that the half-life wasn't that long, a year or two. Now the half-life is thought to be over 10 years. So this basically doesn't go away. Now, is it an absolute contraindication? It borderlines being a absolute contraindication. So here's what you have to do. Number one, I have a new bisphosphonate consent form. So make sure that you get that new one and use that, Cassandra, not the old one that I had. I made one a little bit better. Number two, make sure that you get physician clearance in writing. Number three, you have to make sure the patient understands that this is a heightened possibility of an osteonecrosis. Now, I have seen them. I highlight some in the textbook. Even in my lectures, I have it. So you have to be very careful with reclass. The FDA is that package insert can be used against doctors. So what I would even tell the patient is, and I'll send it to you. If you email me, I'll send you the package insert where it says, even explain that to the patient that this is what the FDA shows. So most of the time, the patient will basically understand that and still want to go along with it. So with that being said, that is your main issue here. Okay. But
Yeah.
it looks like you've taken care of the majority of that already. Okay.
Yeah.
So let's say that everything is good to go. What are we looking at, or where are we looking at?
So she has upper and lower partials, absolutely hates her upper partial. So really wants a upper all on X. 2, 3 are questionable at best restorability from caries into the already root canal treated plus radiolucencies. 15, not good, up into the sinus.
Yeah.
12, whatever we're calling that premolar, non-restorable. So I agree that edentulating the maxilla is in her best interest.
Okay,
My plan would be extract all the uppers, get pathology out, graft, put her in a interim removable denture, and then proceed with planning that all on X case afterwards. If
okay,
dental facial risk is really low, should be easy to make it look pretty
okay.
for her. And then
So,
2 lower implants on each side.
okay. So let's first look, let's do a cross section through molar to molar on this, Hussein.
You got it, sir. I'm going to start with tooth number 2. And here we go, Dr. Resnik. So there
Oh
is a
yeah.
periapical pathology.
Yeah, that doesn't look good. Keep going, keep going, keep going, keep going. Okay. So Cassandra, this is not a good, I know that you weren't planning on, hold on, go back. So it's a good odontogenic sinusitis case.
That's what I
So
was
yeah,
thinking.
see it, yeah, see how that is? Um, so you were right on the money. Not a good immediate case. So you need to eradicate all this infection, take the teeth out, graft it, and then take a new scan, come back and place the implants in the ideal position. Now, I think you do have enough host bone in a lot of these areas. It is a little compromised in the molar area, but I think in the cuspid and the bicuspids, you're going to be all right. So phase 1 of this, you always, are we looking at the mandible also on this?
Yes, 2 posterior implants on each side, keeping the anteriors.
Okay. When you look at staging how to do maxilla-mandible, we know the maxilla is always going to take the longest, so you always want to start there. Secondly, you want to start working on the plane of occlusion and any maxillomandibular relations that need change, vertical dimension, whatever. So I like your plan. You were 100% on. Phase 1, extract, graft. Phase 2, implant placement. Phase 3, and you might even be able to immediate load the placement on it. Okay.
That's what I was hoping, just
Oh,
reevaluate at that point, but seems
yeah,
likely.
yeah. You could probably yeah, do this. This is a female, you said?
Yes.
Okay. Okay, good. So the maxilla, we'll work with you on that one. So just for time's purposes, let's go the mandible.
Yes,
Because
sir.
you're right on the money. And I think you said 2 on each side in the posterior. Is that what you
Yes,
were
he
saying?
has first premolar, so second premolar, molar on each side.
Okay.
I
Hussein,
don't think
did
it
you
makes sense to get rid of those other teeth.
Keith, Hussein, did you work this up for
I, I
implants?
I did plan it for like an all next on the bottom, Dr. Resnik, rather than planning
Okay.
implants posterior segment.
Okay, so let's look at the posterior. Let's see what it looks like.
Here you go, sir.
Okay, so blow that up right off the bat. Okay, so Cassandra, do you see, show her the difference or show everyone how much of the buccal plate has lost. You probably lost about 6 millimeters of that buccal plate, even more than that. Yeah, that's kind of where, so right, see how the ridge has turned all the way to the lingual? So you
Yeah.
need a significant bone graft there, Doc. That's going to be probably about a 4 or 5 millimeter bone graft that you're going to need. Let's look at the other side.
So would
and
you, like, how do you determine to graft it versus reduce a little bit to get a flatter?
Well, let's
Occlusal
take a
table?
look at I'll answer that in a second. Hold on. Keep going.
Okay.
Keep going. Yeah, same Cassandra on this one, the same thing. So let's go back to the Panorex. Okay, let's blow that. Now, what was your actual question? So I get that right?
You talked about doing GBR there significantly. My question is, like, thoughts on creating a flatter occlusal table to place the implant on, since we're quite a ways away from the nerve, or combination of the two.
Yeah. So, well, let's first talk about your options. What I would tell this patient is there is two options. One option is to place the implants in the posterior. But what you're going to have to do is do bilateral
So thank you very
grafting.
much to people who have
Okay.
joined us on Club.
Okay. You're going to have to do bilateral grafting, which is going to be rather significant. The anterior teeth look fine root structure wise, but you do have some significant attrition on those teeth. So they're not perfect. Therefore, one option also would be to take those out. And I think that's what Hussein was looking at. It would be probably a lot easier to take those teeth out than to graft the posteriors with the plane of occlusion. You're going to have a crown to implant ratio. See the difference in the height of where the teeth are to where the alveolus is? It's pretty significant. So with that being said, to grow bone in width is one thing. To grow it in height is a lot more difficult. And I think that would be very difficult in this case. Therefore, if you look at, and it's truly an option to take those teeth out, just go ahead and put the implants in that you had treatment planned. Okay. And he'll show them to you here in a second. Okay. So you got 5 implants in? Okay.
Yes, sir.
So Cassandra, you might think that's a little aggressive, but if you look at the path of least resistance to what the patient wants, they want function and aesthetics, this probably would be better. However, what I would highly recommend is you give the patient both ends of the spectrum, keeping the teeth, not keeping the teeth, and give them the advantages and disadvantages. I think long term, I think the implants would be more predictable in the anterior. I think morbidity and complication wise, it would be less with placing implants in the anterior. That doesn't mean that you have to do it because those teeth, you'd be taking out teeth that aren't that bad. However, looking at the prostatically driven treatment plan, which is a final prosthesis with a good occlusal table, and you're doing an all-in-X on the top, would probably be more ideal to edentulate them and do one on the bottom. If not, you're going to make a maxillary fixed prosthesis that might not be ideal with aesthetics and function. Does that make sense?
Yeah, and Hussein was absolutely spot on in that this was what I asked for initially. She was thinking upper and lower all on X, and then just today came back of like, well, maybe interested in keeping the lower front teeth.
Yeah.
What would that look like?
They're super erupted a little bit too, so they're going to throw off all the maxillomandibular relations. So,
okay. So if we were doing the lower arch, you would not put anything posterior to the foramen?
No, you won't have any. There won't be enough bone to do it, nor do you need
and
it.
no real need to.
Yeah, you don't need to. And he can, Hussein, can you play around with those and maybe even angle those? Not now, but later on. We can probably get them more distal for you, Cassandra. So we can probably get those into at least the second bi area where your frame, is that the first bi?
Right now, I'm at tooth number 21 and number 28.
Oh, yeah, you can definitely you might get into the first molar area. So, yeah, we can play around with that. Okay?
Okay, sounds good. Thank you.
Questions?
No, that's that. Where do we go to get your consent forms?
Go right on. Are you doing the modules right now?
Please continue to join us with the Yankee State.
Okay. You can go on the website. Go on the website. It'll say forms, and they're all updated. So I have new ones for all on X. There's a new just specifically for all on X. I have new biologics. I have new bisphosphonates, smoking, and alcohol. So they're all new forms that were just put up in the last month.
Okay, great.
You probably have the old ones. So
yeah.
Okay. So get those. Okay. Okay. And we have Dr. Kuzman, our last one. How are you, buddy?
Good. How you been?
Good, good.
Good.
You never have an easy case. So
No, no.
okay, so and I can see right now no one had bone tonight. So what are we looking at, Doc?
So the patient originally presented because he was missing his lower anteriors and didn't like the way it looked. And obviously, he's got advanced periodontal disease. And through our discussion, we talked about doing all on X bottom maxillary and mandibular.
Okay, so let's just look at the maxilla first.
Okay.
So all these teeth are non-restorable, right?
Yeah. Yeah.
Okay, who's saying get rid of them?
Yes, sir.
Okay. So he has retained some bone, horizontally at least, vertically no, but okay. So let's go ahead and look at cross sections and see what we have. So Frank,
Throw it away,
you
Dr.
weren't thinking of doing this immediate, were you?
Well, that was what I was kind of
Yeah.
contemplating if we, because I don't know that we'll be doing any sinus grafting. I was trying to see if we can angle to get enough
Oh.
AP spread. No.
Yeah, I doubt it. Oh my gosh.
Okay.
Yeah, that
Yeah.
it would never. You don't have enough bone.
Okay.
There's no way. So if
Yeah.
you look at our key implant positions, Frank,
Right.
cuspid, molar, bicuspid,
Right.
they're going to need grafting. So I would phase one of this, extract, remove all this infection, graft it out, just graft the sites that
Okay.
are going to need the implants, and then delay that. But there's
Okay.
no way
Yeah.
that would work. No way. Yeah.
Yeah.
It's
Okay.
just too advanced. Yeah. Okay, let's look at the lower. I don't think Frank in 20 years has ever shown me an easy case. So
Well, why would I want to do that? That's
exactly,
no fun.
exactly. Okay, so let's take a peek. What do we have on the lower? Kind of the same. You said missing
Kind of the
lower.
same.
Okay.
Yeah. Like
So,
I said, he came to me because he didn't like he was missing his lower anteriors. So that was his main concern.
okay, so let's look. Oh yeah. Okay, now this one could be different. Let's go ahead and let's do a cross section between the framens. You'll
You
never
got it,
get
sir.
anything behind the framing
Right.
because
Right.
yeah, but let's look between the framens. Keep going, keep going, keep going, keep going. No problem, Frank.
Okay.
Extract them, reduction guide,
Yeah.
and you want fixed on this?
Yeah.
5 implants, maybe maybe you can even angle the posterior ones. I think you can.
Okay.
This will be real straightforward for the lower. So
Okay.
see how the AP spread isn't that great?
Yeah. Yeah.
So Hussein, if you work this up, angle those a little bit to increase the AP spread, and
You got it, sir.
try to get that. These implants have to go more apical, because when he does a osteoplasty, when he goes more apical, his AP spread will get a little bit better on that.
Yes,
So,
sir.
okay.
I'm on it.
Okay. Is that good, Frank?
Yeah. So on the just going back to the maxilla, do you think that's going to have to be like RP5 or RP?
No, I do it fixed. I think
can
you can
do it
do it
fixed?
fixed. Oh, definitely.
Okay.
Yeah,
Right.
there's bone there. The problem is you don't have bone where you need it to place
Right.
immediate implants. And I don't want you to put implants in a non-ideal position just to
Okay.
save time, because
All
they
right.
would be in a non-ideal position.
All right.
Yeah.
So can we avoid having to do bilateral sinus lifts, you think?
I think you can. You have
Okay.
a column of bone right in front of the sinus that I
Yeah.
think that you can angle those implants
Okay, that's what I was
and
thinking.
avoid it. Yeah. Yeah,
Okay.
I think you can. So let's get them out. And Hussein can also work those posterior molars up to see
Okay.
if the implants can be angled. I think they can. And then you graft in that area. So
Okay.
you only want to graft in the areas that you need to, because
Okay.
or you'd be grafting the whole entire maxilla. So
So am I doing width grafting as well as socket grafting, would you say, or
yes,
just
yes,
yeah.
I would do both.
So
Yes.
some tenting grafts?
Yes, you would. But the tenning, so what I meant by that is the tenning grafts are in specific locations
Right.
according to
Okay.
our key implant positions. Yeah.
All right. All right.
Okay.
Cool. All right. So I would,
Okay.
so I should take everything out, graft, put him in a temporary denture prosthesis, let that heal up, and then maybe do the two of them together when we're ready.
What I would do is start on the top because it's going to take longer, put them
Yeah.
into a denture, ideal, and then go to the lower. You can keep them in a PMMA on the bottom
Okay.
while you're doing the top, and then just do them both together. Definitely. You don't want to
Okay.
restore the bottom without
No,
restoring
no.
the top. You don't want to do that.
Absolutely. Yeah.
Yeah,
No,
yeah.
absolutely. Okay.
Okay.
Great.
Yeah,
All
good
right.
case. And I know you
Thanks.
can do it. So, okay.
Thanks.
Hey, thank you for, wow, it's 8:30. Hussein, I told everyone we weren't going to do this. Thank you to everyone. We'll be back in 2 weeks. Great turnout, and we're getting a lot of great evaluations on this. So we'll keep doing it. I want to thank Dr. Robinette and certainly Dr. Hussein Tarek. Thank you very much.
Thank you, sir.
Everyone, have a
Thank you,
good
Dr.
night.
Best.
Take care.
Good night, everyone.
Okay.